So this will be the patient assessment here, since we're not going to be together on Labor Day, along with the anatomy chapter, chapter 6, and this one, chapter 10. It's probably the most important chapters in the book, at least in my opinion. So your normal introduction. Just be aware that the patient assessment is used in every patient encounter. There are 5 main parts here. You'll see all these when we go over the assessment starting next lab period. They consist of the scene size up, your primary assessment, taking your history, which is part of the secondary assessment, and the reassessment at the end. So just one sign or symptom doesn't always just show you what's going on with the patient here. And you need to understand the difference between a sign and a symptom. So a symptom is going to be subjective. It's going to be what the patient feels and what they tell you about, things that you can't see with your own 5 senses, such as how badly they actually hurt from 1 to 10, that sort of thing. That's going to be subjective, just based on what the patient tells you. Now, a sign is an objective condition. It's things you can see, deformity to someone's arm because it's broken, that sort of thing. Something that anybody can see. So the scene size up is going to be your evaluation of conditions there. But it's going to be important that you always maintain a situational awareness. Like I said before, avoid tunnel vision, that sort of stuff. The size up is going to have several things in it. So it's going to be just understanding what could be going on prior to even responding to the call. It's going to be what the dispatcher tells you about the call and anything that you actually observe on scene. So scene safety is going to be paramount in everything. You don't go in if a scene is going to be unsafe for you. So there's going to be anything from minor difficulties, loose steps, that sort of thing, tripping hazards, dogs on scene, to major dangers such as, patients that are going to be aggressive and want to hurt other people. So just be sure that you never enter into a scene unless it's going to be safe for you and your team there. So remember here that wherever you enter the scene, typically that's how you want to leave. And if you're going to be on a roadway, you always got to wear a safety vest. That's going to be policy wherever you work. It's going to be important to wear that safety vest too, because any insurance policy that's going to pay off in case you get hit for your family is going to void if you're not wearing a safety vest on a roadway. So make sure you consider the terrain, anything to do with traffic, because you're going to be responding to vehicle accidents. So you got to make sure that you're going to be protected from any traffic that's going by and any sort of environmental conditions, because we work outdoors. There's going to be rain, snow, that sort of stuff. You got to watch your footing. So here, the important thing is going to be to make sure that anybody that can get hurt is kind of safe, and that all these environments can change from moment to moment. So you always have to maintain that awareness. Okay, anytime you get a call, it could be either a medical call or a trauma call, or it can even be both, such as someone that has a heart attack while they're driving and then crashes into something. Now, for traumas, we're going to use the term mechanism of injury. This is basically going to be the physics involved that could hurt the patient. Yeah, the amount of force. So force is going to be mass times acceleration squared, if you remember from your physics class. What this means is, speed is twice as important in force as the actual mass of the vehicle involved or the mass of the person. It's also going to be involved in mechanisms of injury, like how long the force is actually applied to the person and exactly where it was. So, a force applied to a chest is going to be more concerning than one applied to the foot, for instance. Now, as far as blunt trauma is concerned, this would be things like falls, usually, getting hit with fist or kicked, even baseball bats. What's going to really set it apart is that the patient's skin is not broken. But the thing is that anything that underlies the area where the trauma occurred, any organs, any tissues under there, is what could be damaged. For penetrating trauma, think gunshot wounds and stabbings, those sorts of penetrating traumas. Basically, a small area is going to be the contact point. So, a knife is obviously small, but it can create a lot of damage. So, any sort of open wound has a high potential for infection later on. We're not going to worry so much about that when you first respond to the call. You're going to try and treat things that are life threats, but be aware that they can get infections later. Now, difference between trauma and medical, we're not going to use mechanism of injury. We're going to use nature of illness for medical patients. It's basically going to be what their chief complaint's going to be, what they say is going to be wrong. So it could be things like chest pain or shortness of breath. So always talk with the patient, family bystanders who are on scene who can actually give you some information, and then use your senses for signs, things that you can see, things that you can smell, things that you notice there on the scene. Now, it's always going to be important to see if there's more than one patient on scene, because it could be things like carbon monoxide poisoning. You get a call for a headache, or somebody just generalized sickness. And then you arrive on scene and the whole family has the same symptoms. We generally say that scene's going to be unsafe because of something like carbon monoxide poisoning. But it can also be things like if there's a motor vehicle crash and you only find one patient in the car, how many people were actually in there? Was somebody thrown out of the car? That sort of thing. And these sorts of situations can be really unsafe for. So consider your MOI or NOI early on in the call. Now, this starts before you get dispatched. It starts with what the dispatcher tells you, and it can really help you out in caring for the patient. But like I said before, don't get tunnel vision on this kind of stuff and just throw out, oh, well, this person was in a car wreck. It can't be a medical problem or something like their blood sugar is low. But you always have to think about these things and what could have caused the accident. Here, just remember that whatever BSI, body substance isolation, or PPE protective equipment that you wear should be adapted to whatever you're actually doing. So there are standard precautions, which basically means there's a standard of what sort of protective equipment you should be wearing, and things like if there's blood or bodily fluids, any hazardous objects there, such as if a fire department has to cut someone out of the car. So any place that they cut on that car is going to be very sharp. So you have to watch for that. And then lastly, make sure you watch out for any sort of communicable disease. Something like hepatitis if you visit a jail is going to be quite common. So all these standard precautions should be taking place before you even leave the vehicle. You should always have your basic mask and gloves on. And minimum gloves should be worn. But if there's any sorts of, chance that there's going to be blood splash, that sort of stuff, a mask and goggles should be worn. So you'll see some of these things on your assessment sheet if you actually look through that lab book that we gave you. And one of the things you have to identify in your scene size up is actually how many patients there are. So in situations like when you arrive on a car wreck, the first thing you should probably do is take a good look around the car, walk around a bit, and identify how many patients you actually have. That way you know exactly how much resources you have to allocate to this particular call. Now, if there are multiple patients, especially more than you can take care of at any one time, you should activate incident command, which is basically us saying there's a mass casualty incident here. We're going to need a lot of people. Usually the fire department can take this over. There's going to be chiefs and things on the scene that are really trained in this, but you're going to have to actually take your NIMS, your National Incident, Management System, courses before you start your job anyway, so you could learn more about this, and we'll talk about it later as well. So if there's a lot of people on scene, what we're going to do is called triage, which is something you need to know about. Triage is just sorting the patients and prioritizing these patients based on what their problem is. So some of the things you might need is something like more ambulances, or if there's a hazmat spill, you can call the hazmat team in. And then if a patient is very sick and there's a paramedic unit or an ALS unit in between you and the hospital, so it's not going to take a whole lot of time, you can call for them. You can call for helicopters on places like car wrecks, so long as the amount of time that it takes to get the helicopter is going to be less than the amount of time to actually get someone to the hospital. Fire departments, a lot of times, are going to be a lot of help to you, and they have all sorts of things they can do. So there's high angle rescue teams. There's a water rescue team in Oklahoma City, hazmat teams. Obviously, you're going to be working with law enforcement a lot in situations such as, domestic abuse cases where they call you in because somebody was injured by assault. So in order to know if you need these additional resources, and there are more than just in that list, by the way, you need to ask yourself a couple of questions. Is there a threat to me? First, is there a threat to me? Is there a threat to my partner or to the patient? How many patients there are? Do we need more ambulances and how many? And then do we actually have the resources to respond to these conditions? Do we need to call in other agencies, other fire departments, other ambulance service to come help us out? Moving on to your primary assessment, this is going to begin when you greet your patient. And what you're basically trying to do is to initiate treatment of things that's going to kill people now, what we would call life threats. So the first thing that's going to happen is you're going to check the patient's level of consciousness. And we'll say how we're going to do that here in a sec. And then we're going to check their ABCs, which is just an acronym. That means their airway, their breathing, and their circulation. Now, part of this primary assessment is going to be called a general impression. This is going to be something that determines the priority of care of the patient that you make. You're going to use a clinical judgment to decide exactly what priority this patient is. Is this patient stable or not? Do they have a life threat that I need to treat right now? All right. Is the first thing you're going to do. Now, there's several things that's going to be part of this that you're going to kind of take in and think about when you're thinking about what this general impression is. The person's age, sex, race. These kind of things are going to be important in things like heart attacks, right? Because you're going to think 65-year-old male, overweight. That's going to be someone that's going to be at a higher risk for a heart attack than a 28-year-old female who's an athlete, right? You're going to look at the patient and you're going to be able to tell what sort of level of distress are they in. Are they working harder to breathe? That sort of stuff. Their overall appearance. Do they look pale? Do they look sweaty? All right. Do they look like they're in a lot of pain? You need to see how the patient's sitting, like tripod position that we've shown you before. Don't stand over the patient. Make sure that they can make eye contact with you. Always introduce yourself. It's very important. So you're always going to ask the patient their name, if they're conscious, and you're going to tell them yours. Now, there's several reasons for this, but the main one is because it builds trust between you and the patient. When you give someone your name and you ask them theirs, there's an exchange of information there. And your name kind of carries the significance of who you are as a person. So it's very important to do this back and forth between each other, and it's a quick, easy way to build that trust with the patient. And then you're going to ask them what's going on, what their complaint is. Ask them why they called you out, that sort of thing. And the immediate thing you're going to do is address any life threats, things that are killing them now. And you're going to get better at all this stuff as you practice and as you actually, practice medicine out in the field. And you're going to have to determine the patient's condition. Does this patient, present as someone who's stable, or someone who's stable that may degrade en route, or someone who's unstable? So these kind of things have a, fluid sort of definition, but anybody that's stable is basically, in my opinion, it's going to be somebody whose vital signs aren't going to change by the time you get to the hospital. Now, their blood pressure might be a little low, something like, 90/60, but you can maintain that blood pressure. They maintain their mental status. They're able to answer all your questions en route. Okay, even though their vital signs are a little off, they're going to stay stable throughout the call. And then some people are just going to be stable, but that just from your experience that they're going to easily degrade en route. And then there are unstable patients. Think of people like have been shot in the chest. They may present okay whenever you get there, but there's going to be a high chance that their blood pressure is going to drop. They're going to have difficulty breathing, and it's going to be very hard to help these patients. Now, one of the things that's going to take priority in your assessment is going to be a life threat. That's going to be arterial bleeding, so spurting bright red blood from someone's arm if they had been attacked by a knife, that sort of thing, because they can die quickly from an arterial bleed. Now, we also want to check someone's neurological status. And the best way to do that is to determine their level of consciousness, which we'll talk more about later. But it's going to tell you a lot about how they're actually doing physiologically because of things like you're not going to have enough oxygen to the brain, and that can cause, an altered mental status, a decreased level of consciousness for your patient. Now, anytime you arrive on the scene and a patient is unconscious, you're going to focus first on your ABCs, your airway, your breathing, your circulation. So if unconsciousness is sustained throughout, it should tell you that there's something critically wrong with the patient. It can be their breathing, it can be their blood pressure, their heart's not working, it could actually be a brain problem, those sorts of things. So all these kind of clues are going to tell you that someone's going to be unstable for you. Don't also forget that while it can be something like someone's not breathing adequately or someone's heart isn't working correctly, it could also be things like poisonings and drugs, or just being too drunk to actually have a normal mental status. It could be somebody that's using illegal drugs like heroin. Now, to actually assess a level of consciousness, we're going to start, just to start, by the way, with a mnemonic. It's called ABPU. It's going to be the first mnemonic you're going to learn here, and there are going to be a lot of these in medicine. So the first thing you're going to do, and we told you, is introduce yourself. So is someone actually looking at you? Are they going to respond to that question whenever you get there? Then that person's going to be awake and alert. If, however, you show up and the person doesn't respond to just looking at you whenever you get there, and then you introduce yourself or you call up their name that their family told you is their name, then that's going to be them responsive to verbal stimuli because they open their eyes whenever you call their name. Now, however, if someone doesn't respond to whenever you call their name or you say hello, what you're going to move on to is actually a pain response. This is usually sort of like a trap pinch. You're going to take your thumb and first finger, and you're going to just pinch their trapezius muscle and see if they respond. Do they open their eyes after you do that? Because it's what we would call a noxious stimuli. So do they open their eyes? Are they able to answer questions after that? And if none of that works, then we're going to categorize those patients as unresponsive. So here's a picture from your book with actually inaccurate captions here. So, but there are ways to actually test for pain response. The one that I explained before, the trap pinch, is going to be C, where you just take those muscles of the neck there and actually kind of firmly pinch it, not trying to cause a whole lot of pain or a whole lot of damage, but just enough that someone tries to actually open their eyes, that sort of stuff. The one in the middle seems like a sternal rub. We don't do that one anymore. You can pinch their face, I guess. Now, continuing on this level of consciousness assessment. So, your orientation actually tests your mental status. So, a normal person is going to be what we call ANO4, or alert and oriented to 4 things. Now, these 4 things are person, place, time, and event. And whenever you hear this, it's always going to be in the same order. You have to memorize the order: person, place, time, and event. I'll tell you why in a sec, but first off is going to be person. Now, person is the patient. Can they tell you their name? If they can, then what you need to ask next is place. Now, this can be really general. All these can be really general kind of questions. And they can say something like the city, Oklahoma City, etc. That could be the place. They could say at home. They could say in the ambulance. If they can answer that question, you move on to time. So that can be the day of the week, which I don't really ask patients because I never really know the day of the week myself. So I'll generally ask them the month, all right, which gets a little more difficult. The day of the month changes over. And then if they can't answer that, then we ask them, what year is it? Now, event is going to be the event preceding. So let's say you get called to an elderly female patient who fell, and you think she might have broke her hip. The event preceding was, do you remember actually falling? Or do you remember when we showed up here? That would be the event preceding. So, like I said, this is always in the same order: person, place, time, and event. The reason being is when someone gets altered, they generally and most of the time will actually forget things starting at the bottom. The first thing they're going to forget is the immediate event. Think of things like concussion. They're going to forget the immediate events. They may remember events that were in the past. So one of the most common event questions that we ask almost everybody is the president's name. Now, the president's name is used because it's somebody that we all know, and it's an event that's happened in the last couple of years. Okay, so it doesn't have to be just the person that fell. Do they remember the fall? But more generally, it's going to be, do they remember the last time the president was elected? Do they get the right one? Okay, after that, they're going to forget the time. They're going to forget the year and the month, and then they're not going to know where they are. And the last actually thing that they forget is going to be their own name, which is generally a pretty bad sign. The reason we use this is because it evaluates both long and short-term memory. So the long-term memory is going to be the event usually. So if they remember, 2 years ago or a year ago when the president was elected, and then there's short-term memory stuff. So, actually what happened, why we're there, that sort of stuff. If they can't answer these questions, these ANO4 questions, we're going to call it altered mental status. Now, they could also have something like dementia where they're not usually ANO4. And the best place to actually figure that out is the family member that's there or the nursing home staff that's there. That way, in case they're not ANO4, we know that they're usually ANO3 anyway. So they usually remember things like where they are in their name, and they might even know the year, but they can't remember, longer term events. So any, deviation, any variation from their normal ANO status of person, place, time, and event needs to be logged, and it needs to be passed on in your handoff reports. Okay, this is anything away from their normal baseline, what they are normally like. And we also talked about identifying life threats. Now, there's a long list of these things. Some of this stuff we haven't gone over yet, but you should kind of know. An airway obstruction is obviously, a condition that can cause someone to die quickly because they can't breathe. Just respiratory failure or stopping breathing, which would be respiratory arrest. Any like low blood pressure causing hypoperfusion, which we would refer to as shock. Severe bleeding, particularly arterial bleeding that's spurting out because it's a high pressure system like we talked about before. It's harder to clot. And then your, cardiac output is over a minute and it's your full blood volume. It's going to be, harder to place all this blood that's just spurting out of someone. And then cardiac arrest, obviously. All right, in most cases, begin your ABCs with age, just their airway patency. Now, obviously, there are going to be exceptions to this rule. Things like, oh, I see the patient is spurting blood everywhere. Well, obviously, that's the first thing you're going to actually take care of. In that situation, we're going to use CAB. So we're going to use circulation airway breathing. So you're either going to use ABC, such as when you find a person down and you don't see a lot of blood around them, or then CAB, things like traumas where you can actually see a lot of blood around the patient. So under the airway section, and you can follow along here with the actual lab packet that we gave you in your, either the medical or trauma assessment. Always stay alert, starting with the airway for things that are going to obstruct it, whether it's just their tongue because of the lack of muscle tone, or it's going to be vomit or blood in their airway. What we want to do is make sure that the airway remains open, what we would call patent. All right. And then it's actually adequately open. And things like if there's something that needs to be suctioned, that we suction it. Now it's important, the way that we actually assess whether or not the airway is patent on things like a conscious patient is going to be whether or not they can actually talk to us. That's usually the first sign that they have an open patent airway. But you're still going to listen to how the patient speaks. So are they having difficulty breathing and then only talking in 2 to 3 word sentences and then having to take a big deep breath in because they're running out of air after only a couple words? Or are they speaking in complete sentences? Now, if you spot something that's making their airway not patent, you need to stop then and address that because that's a life threat. So, like I said, in unresponsive patients where there's not a lot of blood around, you don't see a lot of spurting blood. The first thing you're going to do is immediately assess that airway after you get your general impression and the level of consciousness of this patient. That's how you know they're unresponsive because you've already done your APU. You already noticed that they're unresponsive. So, if it's a trauma call or there's reason to suspect it, you would use that jaw thrust. Okay. If it's a medical call, you'd use that head tilt chin lift technique that we showed you in lab. And as always, the primary cause of airway obstruction is going to be the tongue. It's going to be the one that's most common. So, like I said, signs of obstruction is going to be things like blood in the airway, vomit, obvious trauma, that sort of stuff. You also need to listen for noisy breathing, which is going to be generally upper airway sounds, so places above the larynx. Things like snoring respirations. You're going to see this a lot in your career for patients that have low blood sugars. They're going to be snoring a lot of times. Bubbling or gurgling is going to tell you they need to be suctioned. Any sort of abnormal sounds that you hear. Now, watch for respirations that are really shallow or not taking place at all. Obviously, that means you need to move on and then actually give them some VBM positive pressure ventilation attached to oxygen. So always make sure their patient's airway is actually patent and open and that they're actually breathing there. So you're going to check and make sure that they're breathing. How deep are they breathing? Is it too deep? Is it too shallow? Is a patient hypoxic, which would be things like, what's their skin color like? Are they cyanotic? Do they look blue to you? These sorts of questions will help you out when you're assessing the breathing. So we just showed you that BVM skill. The reason you should do this, like BVM skill, is, is someone's respirations above 28 because the normal is 12 to 20. Are they less than 8? If that's the case, they need to be, you need to be using a BVM and then probably an airway adjunct, an OPA or an NPA. And your goal in doing this and giving people supplemental oxygen is to maintain that SpO2 between 94% and 99%. And we went over that, I think, basically the first lab we had. So one of the things you're going to notice here is actually the effort that the patient is giving. Watch for those retractions that we showed you. Any sort of accessory muscle use. Are they really breathing hard with their belly? Are they using their neck muscles to actually breathe? Is there actually nasal flaring going on, which is when the actual nares of the nose actually expand to inhale so they can get even more breath in. Like I said, are they talking in 2 or 3 word sentences? We call that 2 to 3 word dyspnea. Dyspnea just means difficulty breathing. Are they sitting in those tripod positions or the sniffing position, which I'll show in a second? Does it look like they're really working hard to breathe? Are they getting tired just from breathing? So this is going to be that tripod position that you've seen before, where patients lean forward, they'll put their hands on their knees there, and it looks like they're trying to tripod. Now this is the sniffing position. So people will do this actually sitting up in a chair as well. A lot of times it's going to be children. Here we have a doctor actually putting a pediatric patient in the sniffing position. So just think of it as, you actually trying to smell a flower. So you don't tilt your head back to smell a flower, but you do like lean forward a little bit with your neck, kind of like this child is doing here, to actually like be in the sniffing position. Now, if you have to put a pediatric patient here, the easiest way is going to be just like in this picture here. You're going to take the opening of the ear and you're going to line it up with their actual sternal notch, which is why you learned all these nice anatomy terms here. So you can actually open up a pediatric airway this way because their airway is a little different from an adult. One of the things you got to watch for is respiratory distress. So that's going to be basically increased work of breathing. Are they working harder to breathe? Are they a little more labored? Okay. So are they breathing faster? That sort of stuff is going to tell you that it's respiratory distress. Now, failure is going to be when their actual blood can't adequately oxygenate. Okay. Or their ventilations are actually inadequate for their actual needs. So there's going to be times when someone needs more oxygen than they can actually breathe in at the rate they're going, like a normal rate. 12 to 20. That's why people start breathing faster, because they need more oxygen. Okay. But what's going to happen is over time when they're doing this, their blood's not going to have enough oxygen, and they're going to like result in respiratory failure if you don't do something. Right. This doesn't mean they stop breathing, but it does mean that they can't get enough oxygen. And the C of ABCs is your pulse. So circulation, there's going to be a couple parts to this. Pulse is the main one. And your pulse is actually that wave of pressure from your systolic to your diastolic that occurs at each heartbeat. And it's going to circulate your blood through those arteries. You're going to have to feel for this pulse, which we call palpation, or you palpate the pulse. Okay. If you can't feel one in an unresponsive patient, obviously go ahead and start. Now, skin is also under circulation. What we're going to do is we're going to check their color. Are they pale? Do they look ashen or gray? Okay. Or are they cyanotic? We're going to check their temperature. The best way to do this is actually, just removing a little bit of your glove from the back of your hand and feeling their forehead. Just like, your mom used to do when you were sick. We're going to check their moisture. Are they sweating profusely? And then we're going to check what's called capillary refill, which we'll have a picture of from your book in just a sec here. So the reason this is under circulation is because the circulatory system actually gives blood to your skin, and when it's not adequate, things change, right? With things like oxygenation. So you can actually shunt the circulation from your extremities, like your arms, your legs, when you get too cold. And then it's going to try and actually just shunt all that blood into your core to keep the bottle warm and actually have the blood, that sort of stuff. That's going to be in this skin circulation, test. So the color is going to be determined by blood actually circulating through the vessels. So if you don't have a lot of blood circulation through your vessels, you're going to look pale. Okay. You can be, ashen or gray, and it's not a good color, and you're going to immediately notice it on people. And this is cyanosis if you've never seen it. You can see this baby here, around the mouth and around the mask area. There's cyanosis. There's a bluing of the skin here on this, pediatric patient. Pediatric, especially newborns, they're going to have cyanosis generally around this area when they have trouble breathing, and they're going to get, this mask area is going to become cyanotic. What it basically means is that the blood there doesn't have enough oxygen. So normal skin is going to be warm to the touch, but not hot. Now, abnormally, it's going to be, hot, like they had a fever, or cool. It can even be cold in hypothermia patients. Patients that are dead are going to be temperature, so they're going to be cold. Or they can be clammy, which is going to be kind of like cold and sweaty. And dry skin is normal, so a normal, adult's going to have warm pink dry skin. So skin that's going to be wet or moist, or even excessively dry, because that could be things like, staying out in the heat too long, heat stroke, that sort of stuff. And then too hot is going to suggest a problem to you. All right, capillary refill, which I said we get to here. You basically look at it to see if the circulation to the distal fingertips is going to be normal. The reason we check there is because it's pretty far away from the heart, right? So we're going to see if they actually have blood all the way to their fingertips. And we're going to press on their nails until it gets blanched or it turns white or pale. And then we're going to release and see how long it takes to actually return to its normal color. So it's a real easy test. This is normally done on pediatric patients and the elderly. Now, the blood circulation could be or should be returned within 2 seconds. So anything, 2 seconds or less is going to be normal. As you see in the picture, they just press down on the nail bed. It blanches, and then they release, and they just count how long it takes. And as I said, in trauma patients or patients where a lot of blood is around them, the first thing we assess is the circulation. So bleeding from any large vein is going to be just a steady flow. Think of if people get, big cuts on their head. where it just keeps bleeding and it's kind of seeping out, or it's just kind of flowing out. That's going to be venous blood. It'll be a little bit darker than the arterial blood, but if someone gets their arteries cut, it's going to be a spurting flow of blood that's going to be bright red. And we will go over the bleeding control and hemorrhage, actual lab skill in lab, but most of the time to actually stop bleeding is going to be easy because we're going to just apply direct pressure, and that works most of the time. Now, sometimes if there's bleeding on an extremity, we're going to apply a tourniquet. So that's going to be used if direct pressure is not, working quickly. And there's like arterial blood. The first thing you're going to do is apply that pressure. Now, if the pressure doesn't actually help, you're going to go ahead and go to the tourniquet. So we may just, if someone's having arterial bleeding to an extremity, just go and put our hand over to have our partner hand us the tourniquet and apply it immediately. Now that these ABCs are done, the part of the assessment we're going to move to is a rapid examination. So that's going to be something that has to be taken care of immediately or before transport. Now, this is a quick exam. It only takes about 60 to 90 seconds. It's not systematic, so we don't just look at someone's circulation. We go head to toe very quickly looking for blood or obvious injuries. Okay, so it's not systematic, and it's not focused on the patient's problem. We're going to check everything on these rapid exams. So obviously, if you're in an ambulance and you have to take someone to the hospital, it's not always going to be lights and sirens. You go to the hospital, and the way that we actually determine whether or not we use lights or sirens is going to be that primary assessment. Okay, was there a life threat there that we had to correct that now we need a doctor to look at? That's going to be a high priority patient. It's going to be those that are responsive, unresponsive, not breathing adequately, not breathing well, difficulty breathing, uncontrolled bleeding. Now, your high priority patients are going to be people that have altered levels of consciousness, severe chest pain that you're concerned they're having a heart attack, pale skin, poor perfusion, loss of blood loss, that sort of thing. Any complicated childbirth, which we'll go over in the OB section, so not normal childbirth. Severe pain for the patient will generally be considered high priority. One of the important things about trauma care is going to be this concept of the golden hour, which is basically the amount of time we want to have from the actual injury occurring to when they get to definitive care, which is generally going to be a surgeon. Okay, so that's treatment of shock and trauma has to occur. All right, and it's going to be immediate transport. All right, that's going to really help the patient survive. Now, this idea of the golden hour, where it's an actual 60-minute time frame, some people might have that 60 minutes. They might have more. They might have less. But the concept is still the same, where we try and treat and transport the patient as quickly as possible. Now, one of the things to also note in this golden hour is the concept of the platinum 10 with the initial assessment and intervention and actually packaging. So your goal on scene of trauma calls is to get on scene, get everything done that you have to have done, and then leave within 10 minutes. So at the end of the primary assessment, you're going to actually determine the priority of the patient and then transport the patient. And that decision to transport, like what hospital the patient goes to if they're critical, is based on several things. Now, one is going to be where the patient wants to go. If they're actually stable, they can basically go anywhere. But let's say that they're not or they're unresponsive. The actual decision that you're going to make is going to be based off their condition. Like if there's advanced care there that they could use or not, that you actually need to stay around so they can use it. All right, how far away the hospital is, and of course your local protocols. All right, beginning the secondary assessment is going to be your history taken. So this basically provides details about whatever the patient's chief complaint is, why they called, what they say their problem really is, and the patient's signs and symptoms. So it's going to include their demos. Okay, so when the incident actually happened, because some people call us after the incident a day or maybe two after that. Their age, gender, race, their past pertinent medical history, and then their current health status. So things like actual age and then biological sex of the patient. All right. And race plays a part here. So generally speaking, male patients that have chest pain and are having a heart attack will present with different signs and symptoms than a female will. All right. And uh, things like race come into play because different diseases are more common in different races. So when you're taking these histories, you're going to be investigating their cheek complaints. Okay. So you made your introductions, your patient's comfortable with you, and you actually get, fully informed consent to treat. All right. You just need to ask a few simple questions of these patients to actually figure out what's wrong with them. Now, these questions are usually open-ended, which means that the patient can't respond with a yes or a no. Okay, they need to actually give you more details there. And the details that they give you, that's where, all the really pertinent, like important information comes from. Now, if they're not responsive or they're altered, the best information is going to be from family members that were actually present when it happened, family members that take care of them normally, even, a bystander that witnessed it. Of course, any medical alert jewelry that's going to say that, like, this patient has migraines, that sort of stuff. And, any actual documentation they can produce to you, things like medication lists, all right, or a list of, allergies or a list of diseases the patient actually has. And there's another mnemonic we used here for a history taken, which you're going to have to know. It's going to be OPQRST. Okay. So the onset is when this started, and the P stands for provocation or palliation. Okay. So that means better or, worse or better. So on onset, you can just ask the patient, tell me what you're doing when this started. When did this start? For provocation or palliation, okay, you told me this, sign or symptom, this cheek complaint. Tell me, does anything make it better or worse? That's going to be your provocation or palliation. Quality is going to be, hey, can you actually tell me or describe to me what this feels like? Because that's going to be an open-ended question. Think of things like chest pain. All right. So chest pain, it can be described in several different ways. It can be sharp or it could be a pressure. They may say it feels like an elephant sitting on their chest. Those are good quality answers. Okay. Region or radiation. So this means, can you tell me where it hurts? Okay. Besides where you just told me, do you hurt anywhere else? Radiation is going to refer to things like if they're having chest pain, does it actually progress down their left arm? That's going to be radiation. Now, I wouldn't actually ask the patient if the pain is moving anywhere because that's just a yes or no question, right? And we want to keep these open. So I want to ask them, do you hurt anywhere else? Well, yeah, besides my chest, my left arm hurts now. That's going to be a good open-ended question. Severity is going to be easy. You're going to ask the patient, okay, from 0 to 10, with 10 being the worst pain ever, can you rate your pain for me? That way they have a whole list. It's not just, one answer that they can give. They can go anywhere from, 0 to 10. And then the last on the OPQRST is going to be time. Okay, so this can be several things, but since usually I ask when this happened and what were you doing when this happened in the onset, for time, I'll generally ask the patient if the pain is actually constant or does it come and go. Basically, is it always there or is it intermittent? Now, the reason we ask these OPRST is because they're actually very helpful in giving us information to determine the cause of the patient's pain or the cause of the patient's problem when they have pain of unknown origin. So it's going to be important with things like abdominal pain because there's so many organs in the abdomen. The way they answer these questions, what were they doing beforehand? How bad is it? Where is it? Do you hurt anywhere else? That's going to help us determine what the actual cause is. And that's why we would use OPQRST. Now, it's important to identify your pertinent negatives. And we talked about these before. These are going to be things that you expect to find, but you don't. You think they should be there if it's causing, it's the cause of the problem is this or that, and it's not there. So, the most, general example I can give you, if someone has chest pain, you might expect that someone's going to have, an engorged jugular vein, that you can actually see something we call JVD, jugular venous distension. If that's not there, that's a pertinent negative. If it is there, it's a pertinent positive, because we would think it's likely that someone that's having chest pain is going to have that JVD. All right, here's another mnemonic for you. This is number 3 so far. So, like I said, there are a lot of these in medicines, even more than we'll teach you. The next thing is going to be sample. All right. So the first thing is going to be signs and symptoms. You're generally going to get this from your patient when you first start your ABCs, because you're going to get the chief complaint. They're going to tell you what's wrong. When you do your assessment, you're going to actually see the signs there. The next thing you have to ask the patient is there allergies? Are you allergic to anything? And then any medications that they're taking, including oral contraceptives, because those do have side effects. So they might present a med list for you, or they might actually tell you what medicines they're on. Sometimes you might have one of the firefighters or your partner go into the patient's bathroom and look through the medicine cabinet. What medicines have the patient's name on it? That sort of thing. P in sample is going to be your pertinent, which means what actually applies to the situation, past medical history. Generally, an appendix, surgery when they were 7 years old and now they're 70 years old doesn't really apply to the current situation. But anything that's pertinent to this actual situation, things like high blood pressure or diabetes are generally the ones that we think of. L is going to be last oral intake. What you're going to ask the patient here was, what's the last thing you ate or drank? When did you eat or drink this? The reason we ask this is for if the patient has to go to surgery, then we want to know when the last time they actually ate, so we know if, there's a likelihood that the patient's going to vomit. And then E is going to be your events preceding to the injury or illness. Now, we've already asked that with our OPQRST, like I said, with the onset. Tell me what you're doing when this happened. If you forgot to ask that on your OPQRST, or you start with sample, this way it can actually, one leads into the other. So, simple, slide here on critical thinking. Just some terms. Gathering is actually seeking the facts. Evaluating is what you think the information means, and then you synthesize by putting all that stuff together to actually form a plan. Now, anytime the person has drank alcohol or used drugs, meaning illegal street drugs usually, the actual effects of those drugs and alcohol can mask or hide any signs that may be pertinent to the situation. Now, if someone has, drank a lot of alcohol or they're on painkillers, obviously they may deny having any problem at all. And whether or not you can actually see something, they'll just deny it to your face. Now, these people, because they're generally altered, may be unreliable historians. Another kind of unreliable historian would be somebody that has dementia. All right, whatever the case, if they're on drugs or alcohol or whatever, don't judge the patient and always be professional. So any scene that you even suspect, physical abuse, child abuse, or domestic violence, you have to report those. All right. Follow your protocols in this situation, but don't accuse people. Instead, make sure that the police, are aware of the situation, that they come to the scene. That way, they're the ones who investigate this kind of stuff. All right. There are some sensitive topics that we have to ask the patients about. Sexual history is going to be one. Now, it's very important. This is sort of a maxim in medicine. All females of childbearing age are pregnant unless proven otherwise. Okay. So no matter what their complaint, difficulty breathing, if they're 24 years old, we have to actually investigate sexual history, because things like actually being pregnant increases a female's, risk of a whole host of diseases, including things like stroke. All right. So, actually getting pregnant is going to probably be the most dangerous thing that a woman's going to enter in voluntarily throughout her life. Now, in this country, it's not, the biggest problem for people because these side effects are rare, but they do happen, and we have to investigate it. So anytime a female is a patient for us, no matter really what the complaint, we have to consider them pregnant. All right. So things like ask about their last menstrual period, because you can ask, is there any possibility that you're pregnant? Yes or no, because they would know that answer. And then investigate further last menstrual period. And then, how was it? Was it a normal flow? Was it just spotting? Because that can happen in pregnancy. On your male patients, ask about urinary symptoms, okay, because they can have prostate problems. They can have urinary tract infections. And then when appropriate and we'll teach you about these situations, you can ask the patient about potential for STDs. Now, some patients just don't want to talk to you, and that's okay. Right? So there may be silence there. So patience with these patients is important. Always maintain a professional attitude. Okay. And these sorts of patients where even if you're asking open-ended questions and they're using, just one or two word answers, like, when you're going through a PRST, right? So you're going to ask the patient the quality question, the Q in a PRST, and you're going to say, describe what this pain feels like. And they're just going to say it hurts. They're going to give you those short sort of answers in those specific situations. Using close-ended questions that are just a binary answer, a yes or a no, can be helpful for you, right? Always try first to actually ask the open-ended question. If they don't answer the open-ended question, then you can switch to a closed-ended question, okay? But always think, is this silence just the patient's personality? Do they not trust people that may have some sort of what they perceive as authority? Or is it a clue to the patient's chief complaint? Are you asking somebody that might be having a stroke a question and they're silent? Well, that might be because of the stroke that they can't actually answer you. So these close-ended questions, I just have the arrow here just so you remember that this applies to people that are not talking to you, not the normal patient. Now, the other extreme is also the overly talkative patient. And this can also clue you into, what the patient's problem is. Things like, illegal street drugs, especially, the stimulants, things like cocaine, methamphetamine, PCP. All right. Any underlying psychological issue, which can cause people to actually be talkative more so. Okay. Like, think about people that have, bipolar, and then they might be in a manic state and they'll be more talkative then. All right. Or they just might be a nervous patient, that sort of thing. They can also be more talkative for that. So don't just think that's their personality. Try and investigate why this may be the case. In situations where you're going to have more than one patient, be sure to always prioritize the patients based on the severity of their symptoms and their signs, just as you would in triage. Okay, so always start with the most serious patient, the patient that is at the greatest risk of dying, and end with the less serious. Now, when you show up, it's going to be an emergency to the patient. It's going to be an emergency to their family members. So certainly anxiety can be taking place. Okay, now people are going to show signs of this anxiety, which your book's going to call psychological shock. It's not the same sort of shock we've been talking about before, but they can get things like, become pale or start sweating, short of breath, certainly. People that have anxiety, especially if it's been going on for a while, an acute attack that's been going on for a while, will develop numbness in their hands and feet. It's because they're breathing too fast. It's a simple way to think about it. They can be dizzy or lightheaded for the same reason, and then they can actually pass out from this. And since we went over these stages of grief, we know that the patient themselves or their family can be angry or hostile. Okay, so they might be talking to you, but it's generally not about you. So always remain calm and professional. Okay, and if the scene becomes not safe, always get it secured. Make sure PD is on scene. If you have to leave the scene, leave the scene. So this is important here. Don't put the intoxicated patient, whether on alcohol or drugs, in a situation when they feel threatened, because that fight or flight's going to kick in. And if they're on things like stimulants, like cocaine, that's going to lead them to try and run away from you or try and fight their way out. Even though they don't want to hurt you, they want to get away. So they're going to try and fight their way past you. Okay, so there's always going to be that potential for violence. And then these drugs, things like alcohol or, the painkillers, they do dull the patient's senses. You're going to have a lot of crying patients, and this is male or female. So just remember, remain calm. Listen is going to be important to what they say. Right? Be patient with them, but be confident in your skills and reassure the patient. And then maintain a steady, soft tone of voice. Now, the important thing about depression, and especially, patients that have, attempted suicide that you take in the hospital, right? Be a good listener with these people. A lot of times they don't want to talk to you about their problem. Okay. But they're going to like just tell you that, oh, this is just how I am. And those sorts of like blanket statements that are very common. All right. So then's not the time to actually, give advice to people generally, but be a good listener. And when you're a good listener, they'll open up to you. Now, depression, has several signs. It has on here sadness. It's not always sadness. It could just be where they don't feel anything at all. There are no highs or lows, so they get that helplessness, right? They become irritable. They'll do things like sleep for 18 hours a day. They'll develop eating disorders where they eat too much or eat too little, and then they're never going to have enough energy. Confusion can occur because of many different things. Altered mental status has a long list of medical and trauma diseases that cause it, but the most common are going to be basically low amounts of oxygen, hypoxia, if they're having a stroke, things like diabetes, whether their sugar is too high or too low, medications they may be on or may have taken from a friend, or any sort of drug that can actually alter the patient's explanation of the events. Now, there's also, older patients that have dementia or become delirious, things like Alzheimer's disease, Lewy body dementia, that sort of stuff. You're also going to run on patients that have limited cognitive abilities. And what's important on these patients is you don't talk to them like they're children, okay? But keep things simple and don't use medical terms, right? You don't need to use myocardial infarction for heart attack. Heart attack, they understand that. All right. Or pain in their chest, that sort of stuff. But be alert for partial answers and always keep asking questions, but be respectful. All right. What's important with these patients, especially if they don't communicate, is to rely on whatever caregiver is there to actually supply the answers for you. And they may even ride with you to the hospital to give you these answers. And there are, of course, cultural challenges. All right. Again, don't use medical language for patients. All right. Depending on what culture they come from, like think somebody from the Middle East, they're really going to prefer to speak to someone of the same gender and to be assessed by someone of the same gender as them. All right. So if at all possible, get the assistance of their friends or family that are there taking care of them, and then try and get help from other healthcare providers that are from the same culture or background if you can, or at the very least, before you even come into a scene like this, talk to people that are from different backgrounds so you can find out what the cultural norms are of the people that come from certain areas. Now, with language barriers, always try and find an interpreter if possible. Usually this is going to be the patient's child. Okay. Now, if you can't find an interpreter, all right, see if the patient can understand actually who you are and why you're there to help them. Google Translate actually helps in this a little bit, even though the grammar is not the best. You can type out questions for them and they can try and answer for you even on your own phone. All right. So keep your questions really brief and short. You can use closed-ended questions here. You can use hand gestures. All right. But be aware of the sort of like diversity that's going to be in your community. So if you're in places like Oklahoma City, there's going to be a lot of different cultures. The most common ones are going to be things like Hispanic culture. There's a large Vietnamese section of town, etc. So you should know what these sorts of communities are and where they're located in your service area. Patients with hearing problems. All right. So be sure you ask questions slowly and clearly, but that doesn't mean you have to shout if they're totally deaf. If they have hearing aids, yeah, obviously raise your tone of voice. So if they actually have poor hearing and they don't have their hearing aids, you can give them your stethoscope so they can actually hear better. That works sometimes. Learn simple sign language for the deaf population. So there's several that I think were in your book before. Things like help is really easy. And then you're always going to have, you should bring a pen with you anytime you're working on an ambulance. And then there's going to be paper there so you can actually write out questions. For the visually impaired, always explain what's happening because they can't see you moving. They can't see what you're actually doing. And then if you're in their home, anytime you move it on, be sure you put it back where it was so they don't trip later and hurt themselves.